para poder continuar con la jornada. Tengo aquí una escarapela de alguien que se le quedó, Lina María Lozano. Por favor, el doctor Oscar Arrieta nos confirma si se encuentra ya conectado, o la doctora Emma Verástegui. Bienvenidos nuevamente. El siguiente conversatorio se titula Evolución de la navegación de pacientes en Latinoamérica. Nos acompañan la doctora Patricia Chacón. Ella es jefa de cirugía del Hospital General San Juan de Dios y Fundación de Navegación de Pacientes Oncológicos en Guatemala y está aquí con nosotros el día de hoy. Y el doctor Eduardo Cazap, presidente y fundador de Latin American and Caribbean Society of Medical Oncology. Él está en conexión remota desde Argentina. Invitamos a la doctora Patricia Chacón con su presentación para el conversatorio. Adelante, doctora. Le recordamos el uso adecuado del tiempo.
Buenos días a todos. Muy agradecida a NPI por la invitación para estar en este congreso. Me siento muy honrada de compartir las experiencias sobre navegación que hemos tenido en Guatemala. Voy a contarles una historia prácticamente, una historia de inspiración, y pienso que algunos van a sentirse identificados con esta historia, otros tal vez nos van a compadecer, pero vamos a compartirla. No se ve aquí, ¿verdad? Tengo que voltear. Bueno, entonces iniciamos en Guatemala a conocer el proyecto Navegación de Paciente Oncológico, que fue en el 2021, y fue gracias a NPI a través de su coordinadora, que es la licenciada Nancy Peña. Entonces ella nos empieza a llamar a los seminarios sobre navegación de paciente oncológico. Yo estuve comprometida con estos seminarios y pues siente uno, escuchas de ese proyecto y dices, yo quiero esto para mis pacientes, ¿verdad? Yo quiero esto porque ya en esa fecha ya estaban los resultados en otros países donde trabajan de esta manera, y pues se ve que los resultados finales de una navegación bien aplicada al paciente oncológico, el resultado final a largo plazo es una mejoría en los porcentajes de morbo y mortalidad, ¿sí? Y sin mencionar todos los efectos que va teniendo eso en el trayecto de ayudar al paciente, de darle apoyo y de darle una seguridad en todo este viaje de su enfermedad. Entonces, escuchas eso y dices, qué bonito, o esas frases que dices, ¿por qué no se me había ocurrido antes? ¿Por qué no se me ocurrió a mí? ¿Sí? Entonces, pienso y digo, queremos esto para los pacientes de Guatemala, queremos esto, ¿verdad? Y entonces ahí empieza nuestro camino. Después, un año después, en el 2022, como presentaron hace un rato, nació el proyecto Beacon, que es la iniciativa de la American Cancer Society para prácticamente ayudar a otros países a implementar sus programas de navegación. Entonces ellos reclutan 8 países, ya como nos dijo Gina en la presentación anterior, reclutan 8 países y nos engloban en una plataforma y nos van llevando así de la manita para que aprendamos cómo es un programa de navegación, para que aprendamos a planificar un programa de navegación. Entonces, con mi persona y 4 personas más guatemaltecas, pues nos enrolamos en el proyecto y así es como fuimos aprendiendo muchas cosas o todo lo que sabemos hasta ahora sobre la navegación de pacientes. Y entonces empezamos con mi grupo a hacer nuestra propia planificación basada en los recursos que nos daba. Yo trabajo en el hospital público más grande de Ciudad de Guatemala, que es el Hospital San Juan de Dios. Y entonces, como los países públicos de Latinoamérica, creo que no somos la diferencia, los recursos no es que sean limitados, sino los recursos tienen otras prioridades, ¿verdad? Como ir a parar a los bolsillos de los funcionarios, pero así en todo eso iniciamos a planificar, en este momento todo en papel, ¿verdad? Todo en papel, planeando objetivos, planeando reuniones, planeando cuánto personal íbamos a necesitar. Siguiente, por favor. Siguiente. Entonces, así se volvió nuestro camino para implementar proyecto de navegación en Guatemala. Era una cuesta arriba y jalando un gran peso, ¿verdad? Esto era lo que enfrentábamos, la falta de recursos, la falta de interés por parte de las autoridades. Se les planeaban reuniones, se les planeaba meeting, hacíamos presentaciones con fotitas, con números, con estadísticas, para que conocieran qué era navegación. Y aún así no se lograba, no habíamos logrado tocar la puerta indicada tal vez para que apoyaran el proyecto. Los que escucharon la plática de la doctora Chapman, ella dice, el apoyo para estos proyectos tiene que venir de adentro, tiene que ser interno de tu organización y tiene que venir de lo alto, ¿sí? Tiene que ser alguien con poder que diga, esto yo lo quiero, esto lo vamos a hacer, esto va porque va, ¿sí? Y entonces ya con las personas que están motivadas y que están capacitadas para lograrlo, pues ya se le ve una esperanza a esto. Siguiente. Entonces, esto es lo que hacía el grupo, socializar el proyecto, explicarles qué era navegación. Incluso nos enfrentábamos a personas que hacían gestos de ¿qué están hablando? ¿Qué es eso? ¿Verdad? ¿Qué es eso? A pesar de estarles presentando números de otros países, por supuesto, pero donde sí se evidencia que la navegación del paciente funciona, ¿sí? Sí funciona. Entonces, es una barrera, ¿verdad?, que se enfrenta, que las autoridades no se concientizan o no entienden qué es el proyecto, o si lo entienden, no les interesa y no están dispuestos a invertir económicamente en estos proyectos. Entonces, esa fue nuestra ruta, pero les dije al inicio de la plática, les voy a compartir una historia motivacional, ¿verdad? Porque hasta esto, en estos meetings, en estas planificaciones, nosotros para este año 2025 llevamos 4 años en esto, ¿verdad? Enfrentamos 2 cambios de autoridades, de alto mando del hospital, volvíamos a iniciar la ronda de pláticas y de concientización y nada, ¿verdad? En palabras, qué bonito, es un proyecto, sí, que está bonito, sí, pero ahorita no hay personal, no hay recursos, y esas eran las respuestas que estábamos teniendo. Sin embargo, siguiente, por favor. Sin embargo, el año pasado en mi país, en Guatemala, en 2024, se aprueba una ley que se llama la Ley de Atención Integral contra el Cáncer, ¿sí? Que también fue una ley que pasó muchos años estancada en el Congreso, pero al final se logra que la aprueben, y pues con eso se aprueba una cantidad relativamente grande de fondos para usarla en este tipo de pacientes. Y entonces, revisando la ley, ¿verdad?, en unas letras pequeñitas ahí, porque de verdad así es, en unas letras pequeñitas dice apoyar proyectos de navegación para el paciente oncológico. Entonces, pues descubrimos eso, identificamos que eso estaba en la ley, y entonces empezamos, ¿verdad? Ahora sí tenemos una ley, ahora sí tienen que escucharnos con este proyecto, y entonces viene el final feliz, ¿verdad? En septiembre, el 1 de septiembre de este año, la dirección aprueba el proyecto de navegación de paciente oncológico y nos asignan una enfermera profesional que está ahí en la foto, y nos asignan una licenciada en psicología también para que se quede directamente trabajando con el proyecto de navegación. Entonces, pues hicimos ahí fiesta, solo el grupito de navegación, porque realmente el hospital es un hospital grande, ¿verdad? Es un hospital de 1,200 camas que tiene muchas especialidades y bueno, un hospital público, ya se lo pueden imaginar cómo es, que está en la ciudad de Guatemala. Y realmente las personas que estamos en navegación somos 4 o 5 personas, ¿verdad? Pero que no nos dimos por vencidas. Y entonces, a la fecha, llevábamos 5 años luchando con este proyecto, y entonces al final pues logramos la autorización. Entonces hicimos una pequeña celebración, solo nosotros, ¿verdad? Pero también lo que les quiero contar, de no rendirse y de que empiecen a planificar, porque cuando se dio la autorización, pues ya teníamos todo, ¿verdad? Ya teníamos toda la planificación que fuimos llevando gracias a la plataforma de Beacon, que la escucharon ustedes hace un ratito. Entonces ya teníamos toda esa planificación lista para entrar en acción, ¿sí? Entonces, la licenciada de psicología, que es Lucía Luna, que la ven ahí, ella ya es navegadora certificada, o sea, ya se había avanzado con eso. Tenemos 2 navegadoras certificadas en Guatemala, una es Lucía y la otra es la licenciada González, que nos acompaña hoy, que está ahí aquí en la audiencia. Pero, y entonces eso es lo que estamos ahora, hay que empezar a planificar de capacitar a los navegadores, porque ahora se nos vino una avalancha, ¿verdad? Después de que no entendían qué era navegación y después de los comentarios de que qué es eso, o de comentarios de que nosotros ya hacemos eso, ¿verdad? Mucha trabajadora social nos dijo, pero si eso es lo que nosotros hacemos, y, o sea, totalmente no era así, ¿verdad? Probablemente una parte, pero no tan individualizado como debe ser para apoyar realmente al paciente, ¿sí? Entonces, necesitamos, ahora que ya se inició el proyecto de navegación, tenemos un mes y medio de haber comenzado a trabajar y ahora dirección ya nos pidió el primer informe, ¿verdad? Ahora, si quieren saber qué estamos haciendo, pues ya está el informe, ¿verdad? Ya se les dio el informe y a la fecha ya tenemos 108, 110 por ahí, que pacientes navegados que ya están ingresados en la base de datos. En una conferencia de mañana yo les voy a compartir cómo es esa base de datos para que vayan entendiendo, porque es primordial en los proyectos de navegación. Entonces, eso es lo que les quería compartir, esa es la historia de Guatemala, y entonces estoy segura que en el Congreso del próximo año ya les vamos a poder compartir experiencias propias, ¿sí? Y les vamos a poder compartir el crecimiento del proyecto, porque como ustedes ven ahorita son 2 personas y yo que estoy atrás, ¿verdad? Entonces tenemos ahora que concientizar más médicos, porque el gremio médico miran navegación así como que aparte, ¿verdad? Eso no nos toca a nosotros, pero sí nos toca a los médicos apoyar y hacer que crezcan estos programas de navegación, porque es beneficio para el paciente y es beneficio también para el médico, ¿verdad? También uno se siente tranquilo, se siente desahogado, que una persona le va a tener más paciencia al paciente, que le va a explicar más despacio, que lo va a estar monitoreando probablemente en casa de cómo va su tratamiento y que va a ir detectando emergencias, urgencias, de cuando el paciente tiene que incluso regresar al hospital, ¿sí? Entonces, esa es nuestra historia. Espero que sea una historia inspiradora, si algunos aquí se identifican con esto. Como he dicho, que ahora sí se puede, ¿verdad? Sí se puede, lo logramos. Muchas gracias.
Muchas gracias, doctora Patricia. Le damos la bienvenida al doctor Eduardo Cazap. Él es presidente y fundador de Latin American and Caribbean Society of Medical Oncology y nos acompaña desde Argentina. Doctor Cazap, bienvenido. Por favor, nos indica cuándo le pasemos las diapositivas.
Sí, buenos días, buenas tardes a todos. En primer lugar, muchas gracias por la invitación a esta reunión importante para no solo los pacientes, sino también para las familias y los sistemas de salud en nuestra región, gracias a NPI y a la Universidad Javeriana. Creo que esta presentación también está muy vinculada al módulo siguiente. Este módulo entiendo que es la evolución de la navegación en América Latina y el próximo son estrategias. Pero la evolución y las estrategias están íntimamente ligadas. Y eh, tenemos que entender que la simple traducción del inglés al español no soluciona los problemas. En muchísimas experiencias de la implementación de nuevas estrategias, técnicas, tratamientos de países desarrollados a nuestra región de América Latina, muchos han fracasado por diversas razones y ya lo dijo la doctora previamente, porque una de las condiciones críticas en esta circunstancia es las condiciones en los países para la implementación de acciones nuevas, en cáncer o en cualquier otra de las enfermedades, en cualquiera de los sistemas de salud existentes. Y empecemos por la palabra navegación. Hay un problema de lenguaje porque usamos navegación de navigation en el inglés, que viene de navegar. Navegar es trazar una ruta hacia un destino. Se usa fundamentalmente en navegación, en náutica, pero también se utiliza en Internet, navegar por Internet. Pero no hay una palabra exacta en español que yo encuentre que significa el tránsito de una persona dentro de un sistema de salud con una enfermedad determinada. Eh, bueno, vamos a decir que está navegando. En realidad no está navegando, está transitando. Y entonces, cuando tenemos que ver este tema, que yo se los voy a comentar dentro de este criterio. Definir qué es la navegación para el contexto latinoamericano, el contexto latinoamericano per se, las fases de evolución histórica un poquito, a pesar que no es un tema tan antiguo, y cuáles serían los retos hacia el futuro. La próxima, por favor. En principio, la navegación es un proceso estructurado, coordinado, de soporte, para eliminar las barreras existentes en los sistemas y asegurar que el paciente complete su tratamiento, en este caso el oncológico, porque nosotros nos ocupamos de cáncer, pero hubo una pregunta anteriormente. En realidad la navegación puede ser para cualquier intervención médica dentro de un sistema de salud. Incluso puede ser no médica, puede ser administrativa o de apoyo familiar. ¿Cuáles son los objetivos de la navegación? Porque en las exposiciones anteriores y lo que ustedes verán en el curso de esta reunión, digamos, hay enormes experiencias, sobre todo de Estados Unidos y de países donde se ha desarrollado bien, como lo hemos visto, en la técnica, en la técnica de la navegación, en cómo se organiza, llamemos más bien el procedimiento interno. Pero yo me voy a focalizar más en el procedimiento externo. ¿Por qué? Porque los sistemas de salud en la Argentina, en México, en la mayoría de los países de nuestra región latinoamericana, dependen de los gobiernos, son gubernamentales. Por supuesto que existen sistemas privados también, pero, como se ha dicho, sin una definición política y sin un apoyo de los sistemas de salud gubernamentales, es muy difícil o imposible implementar un proceso como este. Entonces hay que explicar tanto a los médicos como a los decisores, como a los que definen las políticas públicas, que acá es una ganancia para el paciente, para el sistema de salud, una economía de recursos y es una ganancia para el país más allá de evitar padecimientos, molestias y realmente disconfort a una persona que además de su enfermedad maligna tiene que transitar por un sistema de salud inhóspito. El objetivo clave es reducir el tiempo de demora, entendemos en diagnóstico y tratamiento, eliminar las barreras, tanto financieras como geográficas, transporte, incluso lingüísticas y culturales. Hay que saber cómo se navega en instituciones y en grupos minoritarios, como pueden ser en la selva amazónica o en poblaciones indígenas. No es lo mismo que navegar en la Mayo Clinic. Y también hay que medir, aumentar la satisfacción y la adherencia de los pacientes y sus familias, porque todos sabemos que en la enfermedad oncológica es una enfermedad que afecta a los pacientes junto a sus familias y a la sociedad en su conjunto. La próxima, por favor. Entonces, ¿por qué la navegación es una necesidad? No es una opción. Es una necesidad
Navigation
porque
is a
ante la
necessity, it's not
fragmentación
an
que
option,
hemos mostrado en
because
dos
in the phase of
anteriores slides,
fragmentation, and even more so in data that we have regarding health systems in our states, most of all in federal states, but also in the load of illness is indisputable with the incidence of morbidity and mortality of cancer, the fragmentation of systems, the inequalities, barriers, long waiting lists. Either way, I should say that in these long times, it's not a problem that it's exclusive of our region. In highly evolved systems, Canada, London, England, sometimes someone may have a nodule in the breast, and the time in between the diagnosis or the surgery may be 3 months. In those systems, in Canada and in Great Britain, this doesn't happen in big cities in our regions. Times are usually shorter, most of all in semi-private or private systems. But fragmentation and inequalities are typical of our health systems. Next slide, please. So how did this start? 15 or 20 years back, this was individual. The approach was an individual approach based on the will of people with leading abilities, leading skills. It was never, up to my knowledge, in the majority of the cases, or at least a few times, incorporated to public policies. As it was said before, we came from down up. But regretfully, this way of doing things represents a great deal of work. It's good to give visibility to the agenda, but it is tough to universalize navigation. People that are committed, doctors, nurses, a lack of standards in the beginning. It was lack of leadership. This was not highly accompanied as it is done right now. I like the experience that doctor said. And so the system of the doctor, I can assure you that if I ask to 9 out of 10 doctors in Argentina, if I speak about patient navigation, they will look at me and not understand anything. Next slide, please. And so we had a transition period, external transition, I mean, to the environment and to other countries, where in the beginning global models were adopted. We can see the adaptation of Dr. Freeman's models in excellence with excellent centers. The history of shows, and these has been evidenced when palliative cares started with integrative medicine, when we started to working with health medicine, which are, let's just say, medical intervention that are more updated, and they started with a niche by people, led by institutions on people. In cancer, we started with the memorial in NY, with the FD Anderson, some sort of isolated pockets. And then awareness rose, and somehow the pressure of the civil society and the groups of patients, where they are now one of the most important groups to have political results in health, and the pressure of the civil society. And also,
we started pilot programs generally in more important institutions. This process, ellos habían motivado a todos, did not evolve evenly in our countries. Countries where we already have activity, as you have already seen in these days, but in other practically lack of knowledge, or only at very particular places.
En esta fase podríamos
in this phase that we could call irregular maturity, distribution is not even, but it's more about professionalization, about the formal role of the navigator, professional navigators from different origins, and also the standardization or regulation of the behavior in the route via protocols, guidelines that you have seen and will see these days. But let's say that this is a stage for many other of the human and medical activities. This is still a primitive stage, not only or not just because we are behind, but because the speed of evolution of human knowledge and technology and the scientific advance is overwhelming, which when I started a few years ago to study oncology, it was said that the knowledge in oncology would renovate like every 10 years. I mean, 50%. If you didn't get updated in 10 years, at the end of those 10 years, we know only half of knowledge. Then that pace changed to 5 years. But I would say that if today a doctor in oncology does not keep himself or herself updated in 1 or 2 years, I mean, he won't be skilled to provide the current healthcare. So that speeding the technology, it's also an opportunity for navigation. And how can this be? By innovation in telenavigation, use of mobile phones to help in navigation in less accessible places, using digital platforms. But of course, for that, the system needs to have an electronic medical record or EPC. You know that in many places, in different countries, regions in the same country, as it happens, not all of them have electronic medical records. And in that way, the implementation of new technologies without that electronic medical record is hard. In cancer, that is one of the main diseases. You know, why in cancer and not navigation in other diseases? Because generally cancer is the most organized disease around the world, and it's one of the very few diseases that has worldwide parameters, guidelines, standards, protocols, procedures, recommendations, plans, national, regional plans, international, etc. So, generally speaking, innovation is quite frequent to go through a cancer. But in this kind of interactions, it's not a one-path interaction. And here we can clearly see that communication is a two-way. It's from the doctor to the patient, navigator to the patient, the patient to the doctor, navigator, and the patient has to interact with the system. Nowadays, video consultation is quite common, and there's a series of technological innovations that are used today to detect, for example, so I mean, in Africa, some type of cancer, those that you take a photo to the uterus, and you can send it to other places around the world. So the options are there. But the thing is how we get a right, efficient, and comprehensive integration within the systems. Next one, please. So what are the challenges? And the first one is implementing, and the next one is sustainability. Because there are many things that are implemented in our countries, but a short time later, there is no way for it to be sustained. This is typical of the cancer records. In the we have the leader record, that is the one in Cali, Colombia, that is good records in Costa Rica, in Chile, Uruguay, and a lot of the registration that were 2, 3, 4 years without any activity due to lack of resources. It's not only about implementing an action, but about keeping it alive with people that are active and also monitored and evaluated in the results. It's an important technical point. So the financing is one of the main topics. Funding, you know, getting it from the public systems, and we propose that it should be through the national cancer plans. The national cancer plan for each country should include navigation as a comprehensive part of the system, and of course, be funded. Of course, the scale needs to be expanded, and generally it needs to be in specialized centers, and then move into primary healthcare, and then being integrated into the system. And the measurement of outcomes and the need to have metrics, solid metrics, to prove payers that this is cost effective. There's not only a social result or count for quality of life. The systems spend less money. They are less efficient. I'm sorry, they are more efficient. They're more efficient if there is a good navigation system. Next one, please.
Entonces, ¿cuáles serían
what would be our
visión hacia el futuro?
Vision to the future in a navigation promoted by data and integrated into electronic systems? The navigators and integrated part of the public-private group, the use of algorithms to identify different types of patients that live in distant areas with short money, that they don't have money for transportation. And the last one that I consider the most important, we need to have a pre-navigation that is also focused on prevention. Why? Because there's no way to improve the treatment of cancer around the world and curing cancer that is by preventing and avoiding healthy people from getting sick. That's the cheapest, is the less aggressive. It's very unlikely that with all the knowledge and diagnosis and treatment, we can cure cancer. Yes, we cure many, but not the 100 million cases that we have around the world. If navigation could be integrated into prevention, I think that the number of human cancer cases would significantly go down, and there will be more curability. Next one, please.
Entonces, conclusión.
Conclusion. So we need to move from the individual effort to systemic quality. Patient navigation is not a luxury, act of a charity, or something volunteer. It's a key component to guarantee equality in the oncological healthcare in Latin America. Thank you very much.
Muchas gracias,
Thank you.
doctor.
Thank you very much, Dr. Casar. Let's ask you, please don't leave, so that later you join us in the conversation. We invite Dr. Oscar Arrieta, the director of the Cancer Institute from Mexico, and she's joined by Dr. Verástegui. Go ahead.
Me parece que no se escucha.
No le están compartiendo todavía. Doctor, les vamos a apoyar acá para compartirla y que
So we
ustedes...
are going to support you here. Okay, yep.
Desde acá ya está listo.
Okay, so from here we're ready. Go ahead. Sorry.
¿Ustedes ya la pueden ver, doctor Arrieta?
Can you see it?
Sí,
Yep.
Okay,
Okay.
adelante.
Good.
Sí, perfecto.
muchas gracias.
Para pues manejarla desde acá.
Perfecto. Sí, bueno, vamos a hablar acerca de la navegación de pacientes.
So we are going to talk about patient navigation in Mexico. Thank you very much for the invite. It's an extremely important topic that in terms of early detection of cancer. The next one, please.
Bueno, primeramente,
Well, first,
La situación en
The
México,
situation in Mexico, it's quite similar to what it is in Latin America. We have more than 200,000 cases of cancer diagnosed per year, and out of these, around 95,000 deaths from cancer. We have in the National Cancer Institute, that is a reference hospital, probably the most important hospital in the country about cancer. And we have a patient navigation program. We have a first stage in 2007 and 2013, where the Institute became one of the very first hospitals in implementing the navigation program in support, with the support of the American Cancer Society. And this goes through a system of dissemination with presentations about promotion, innovation. So the next one, please.
Okay.
And we start also with the patient navigation stage in the Institute, 2014, 2013, a formal record of patients. So we have the record of patients and survivors, and focus on donation, support materials, medications, and broad social viability, presence in network, and sustainability. These are in the navigation program, the number of patients that have been navigated through in the Institute. And particularly, we are focused on the most vulnerable population in the Institute for patients with low socioeconomic level, as well as aged patients, elderly patients, where here we see the number of patients that we have taken care of in the Institute in stage. And we have identified different barriers that we have here. First, the problems of navigation, the barriers to entry that we have identified in patients. We can identify three main areas. One is in terms of patient, another one in terms of diagnosis, and another one at the beginning, at the onset of a treatment. One of the most important points is the use of patients. When patients go to the doctor, the first contact when the symptoms are usually on an advanced stage, when the disease is on an advanced stage, is when they go to the doctor, and they are not referred properly from the first to the second level. In this stage, we have barriers that are economic barriers and have a lot to do with the possibility of access to private doctors, that even though you have a suspected cancer diagnosis, we have the difficulty for the patient to be able to go to a specialist cancer doctors. Of course, we have a delayed treatment in terms of diagnosis, where the patient's appointments are in a very extended period of time between one appointment and the other one. Yes, the biopsy, the pathological result, and finally, when the patient is already in the institution, the delayed onset of a treatment due to the time to get the appointment. So it's barriers that are, can be differentiated between the financial support, integration, and logistics. So out of these limitations that we have identified, most of them usually are around immediate support, such as a donation, accommodation, information, and with multiple visits. There is not a clear temporality or timeline of navigated patients. It was not documented, a formal follow-up. And usually the focus is on donations and economic support more than in clinical integration. we lack clinical impact indicators, and is limited to academic production and publication, which is a key to be able to have changes, reliance on external supports, and lack of institutional navigators.
Bueno, actualmente
Well,
estamos
right now,
modificando toda la navegación del instituto.
we
Tenemos
are modifying all the navigation of the institution. We have a technical cooperation with City Cancer Challenge Foundation, American Cancer Society, MPI, and all of these big beacon initiative, and all of this will lead us to particular indicators, formal training, and cooperation in clinical, no clinical navigators, and cooperation with other institutes such as the National Cancer Institute and other second and third level hospitals to be able to achieve this comprehensive navigation.
Y pues ese es un modelo cooperativo en construcción que estamos con un enfoque
And
clínico.
that's the model that we have with this clinical approach. Next one.
Una parte muy importante
A
es
very important part is the work of foundations and volunteers that have been the pillar and helped us to achieve this restructured model of patient navigation. The experience of over a decade of navigation in the Cancer Institute supports key decision lessons. So it's necessary to institutionalize the model, build manuals of procedures that can integrate the navigation system, allocating sustainable financial resources, implementing a more robust electronic records system so that we can prove the impact on access, adherence, and quality of life. Quality of life, yes.
Ese es el final.
That's the end, Doctor. Yeah.
Muchísimas gracias al doctor Rivera
Thank
y a la
you
doctora Vera.
very much, Dr. Arrieta and Dr. Verástegui from the National Cancer Institute in Mexico. So now we invite Professor Sandra Pacheco to Dr. Patricia Chacón to join us on the table, Dr. Arrieta, Dr. Verástegui, and Dr. Cazap.
Invitamos a las personas que nos acompañan.
We invite to the people who are on site if you have any questions.
De las personas que nos acompañan, ¿tienen alguna pregunta?
Any question around here? On site?
Bueno, muchísimas gracias
Okay,
al
thank you very much, Dr. Cazap, Dr. Rivera, and Dr. Chacón for your presentation. I think you have given us a general overview of what happens in our context in Latin America. We see that out there we have a question. Yeah, well, let's go. Let's get us started with questions from the audience around here. Well, while Dini reaches you, there's a question for Dr. Chacón, and it's the funding of the program are provided through the government or through the institution. Yep. The hospital, it's a public hospital, so it means that those fundings come from the staff through the Ministry of Health. So the navigation project was already integrated as one of the projects in the hospital. And it's even yesterday, I was talking to Nancy that they already opened a code as oncological patient navigation. And with that code, we can request for money, hiring staff. We are already looking for the physical space to get an office condition. And then we will get all the office supplies, computer desk, etc. But it's, yeah, money from the government. Thank you very much, Doctor. And I think that answers the next question about whether you implement a government or was it enough the administrative action for the patient navigation program. Yeah, as I was talking about, the implementation and the approval of this law of cancer management that was bill in the Congress. So by being approved, that bill, it had included different projects to help cancer patients, and it included patient navigation. So in our account, we already had a budget allocated, and that's what we are implementing now to include that in the budget that are already part of the government and that need to give us with that code. As I said, we can start for that money. So the initiative of government approval didn't come from us specifically, but that came with the approval of this law. So with that, already authorities in San Juan de Dios, they had to turn around and look at these projects because it's convenient for them now. In terms of the Ministry of Health and advertising reputation, they need to prove how they are implementing those that money, those funding. So now they are interested in all these projects for the execution, because of course they also get audited. So, but not directly. It was not our team that started to do this government. We didn't do that. But now with this, the hospital directors, they disseminated a communication memo in all the offices authorizing the creation of the oncological patient that it's in the, well, for now it's in the surgery, but the objective is to expand that to all the hospitals, sorry. Thank you very much, Dr. Chacón. I have a question for Dr. Rivera and Dr. Cazap. In your countries, the role of navigation is regulated. Is it regulated? Dr. Cazap, we can get started with you.
¿Me la podía repetir la pregunta?
Can you repeat the question, please?
Porque yo estaba viendo
It's
una
about
que
regulation, because I was looking at one that is here. And sorry, apologies. I was reading another one. No. The question is whether the role of navigation in your country is regulated.
Bueno, habría que entender cuáles
Well,
son.
we would need to understand regulation. Does it mean that is within a national law or in some kind of higher structure? As far as I know, no. Okay. Yeah, that's what regulation, meant. If there was like some kind of law supporting this role of this exercise. And in Mexico, Dr. Rivera, we have a national cancer plan that includes, of course, prevention and screening, but the role of navigation is not included. And this is a key that needs to be worked around. The delay that there is between a suspicion of cancer, a patient, for example, a patient with breast cancer, that it's a suspicion until the patient going through the entire process to start the treatment in Mexico, it's usually 5 to 6 months between the moment that actual diagnosis and the suspicion and actual diagnosis usually. So, usually it can become something advanced, in 5 or 6 months. So what's the good in having that law that is supporting for the good screening the patients that we have with cancer suspect or with cancer diagnosis? we have 5 months to start the treatment. So it's a key that this should be included in the law in order to improve the diagnosis and improve for the better stages, early stages. If we build a model where if we can reduce the times 4 to 8 weeks from the suspicion to starting the treatment, we would see we could detect 20% more in early stages. This would not only improve the diagnosis and the prognosis, but it would also significantly reduce the courses of treatment, so that by including this early reference of patients with suspicious of cancer diagnosis, it's essential, it's a key to include that into this law. So now, we don't have this navigation system as like in a bill, in a law. Within the National Cancer Institute, we do have a navigation department for very vulnerable patients, where we have a focus to be able to help the patients to have in the institute some guidance and navigation of the patients in the institute in the same way. The functional units that we have a procedure manual for patients, first-time patients. We have a navigator that helps the patients to get the appointments for the corresponding studies of stage with the pathology study, so that this goes faster and we can make decisions faster. But this insists it's internal in terms of the hospital. I think that you're asking more in terms of at the national level, but I think that is also important to think about that. Yeah, we have called this a cancer code in Mexico, which is essential to be included in the national comprehensive law. Yeah. Thank you, Dr. Rivera. So there we are identifying the challenges that we have in each one of the countries and in Latin America. We have another question here from the audience. Yeah, go ahead. Good morning. Thank you. I have a question, and it's about in this framework of health networks, where it's important to integrate actions from the low complexity to the palliative care of cancer patients. Do you have experiences, one, in defining the profiles of the navigators that play a key role in the actions? I don't know if in your countries you call it primary healthcare, different levels of complexity, but let's talk low complexity that has an orientation towards the early identification of risks, educations, and so on. Now, in the process of early detection and reference for treatment, have you defined profiles? Is the first thing to establish those differentiating characteristics per complexity level, and two, whether you establish some kind of articulation mechanisms between those mechanisms from the low to high complexity to be able to guarantee the continued attention and to have this coordination in the different units, assistance units. Thank you. Yes, that's a very important question. Definitely, there needs to be a definition of the navigator profiles. So we are talking here about inter-hospital references. That work needs to be made by a social worker to talk with the partner in the institution that they will be referred, or the one that is bringing the counter reference, and it needs to involve a clinical navigator. The profile of the clinical navigator, the best one is for it to be a professional nurse, registered nurse, because they will have the knowledge. They will have the clinical knowledge about the disease. Even they will be able to communicate if a doctor takes the phone call to the other reference center, to be able to explain the patient's situation and mainly the reasons of the reference. But the initial links or liaisons, whether that they have a list of all that people that is going to support them outside of the program itself, right? So that facilitates, for example, in cities, you have the name in the interior, the hospital, the name of the person that can support in that hospital to make the reference. However, it's not only one person, but it's 2 or 3 navigators engaged. As I said, the clinical navigator is very important in this reference system because they will be the ones explaining the clinical situation the patient is going through and the main reason for the reference. And the initial contact can be left to a social worker.
Gracias, doctora Chacón.
Thank you, Dr. Chacón. So now I pass the floor to Dr. Cazap.
Sí, muchas gracias. No,
Yes, thank you very much.
digamos, nuestra
Our
área es
area is
básicamente
basically
definir los
defining
alcances y
the
la
scope
forma de entrada a los
and the
sistemas
point of
de
entry to
navegación.
the
Después están los
navigation
equipos
systems.
técnicos
After that, we have
especializados
the more
en
specialized
cuál es el
technical
rol
teams
específico de los
in
navegadores.
analyzing the particular role of the navigators.
En lo que yo
But in the
conozco,
what I have heard or what I know about, always the principle or the onset is through a navigator. In some of the systems, especially in the European systems, they are using the telephone system, where the person that requires the healthcare first, they were served by an administrative person that has these different levels.
Of different levels, that it's recommended to stay in home, get some rest. Maybe they tell them what to have, what medicine to have, or they can send an ambulance, in which the navigation system not specifically starts through or with navigators. Once the person is already inside the system, then we have question. I don't know many systems in Latin America. I don't know if anybody has more experience than myself that knows navigation that it's been implemented through the primary systems of health attention, which would be the easiest gateway to the system. I'm not sure. I'm not aware of it. Thanks so much, Dr. Cazap. Dr. Arrieta.
Sí, es muy interesante la pregunta.
It's a very interesting question because it has to do with different levels. And as the doctor is saying, the one that will unchain the code or the reference are first contact doctors. They identify the patient that have a cancer suspicious. And these can be family doctors, general doctors, internists. They can identify patients and start the navigation referral system. The work within the hospital to be able to make a reference on the patient, we need a social worker that needs to have a direct communication network with other hospital of first and second and third level that may treat cancer. These involves qualified staff that may have not only the proper training, but also the possibility to establish fast communication with other institutions of second and third level. And already inside the hospital, what we believe that the person can do, a key person is the nurse. And this is what we have in the functional units, that every patient that we receive for the first time, but mainly prioritizing most vulnerable patients, this nurse that is specialized in functional medicine to reduce the times of attention for the patients. So these 3 types of specialists, the general doctor, the first contact doctor, the social worker, and also the nurse inside the institution. Thank you so much, Dr. Arrieta and Dr. Cazap. We will here to one last question. Good morning to everyone. My name is Francisco Isabel. I am a clinical navigator of the CETIC Foundation. One of the questions that I have inside the institution, how do you measuring, let's say, the opportunities of diagnosis and treatments, and if you have other types of measurements on an institutional level that we may contrast with the public and private network. I don't know if, yeah. Are you mentioning like indicators of opportunity? Within these management opportunity indicators for diagnosis and treatment, if you do them and if you measure them, yeah, if there are opportunity indicators within the navigation. Dr. Chacón, I'm not sure if you meaning to the database that the project needs to contemplate, and maybe, yeah, like management indicators. Yes, the experience, our particular experience in Guatemala, we have a database that up to date. We are keeping it in Excel format. It's very important. The configuration of these spreadsheets is critical to upload every patient's data and information, because from these spreadsheets you will derive the actions and the modifications to the program itself. So our database include the name of the patient. This is crucial because we need to be able to contact them and call them by their names. And also, we also include the name of the hospital registration. We include the age, diagnose, the date of that diagnose, the date the treatment was started, if it was a surgery, what type of surgery, or if it started with chemo, the date that chemo started, and also the doctor that is in charge of such treatment. There are other boxes also to monitor evolution, what complications, if he had particular conditions, the dates for further appointments. Then we have the psychology appointments if he already saw the psychologist. So this is a quite broad spreadsheet in Excel as you are listening. As I was telling you about, we are starting with this, but these, regarding the project of navigation, this is the core of the project, because this is where you will pull off your indicators and measure timelines. For example, how long is whatever patient taking to be diagnosed and to receive his or her first chemo. So when you analyze the data and you see that maybe the timeline is too long, you need to incorporate the corrections to reduce such time. So this is the utility of these database. And also, when you're already implementing the project in the hospital wants to see the results and they want to be reported. So you need to file the reports, you need to present your reports. This is been done on a daily basis through our follow-up of the patient. And when you do it, it's just a click away. Thank you so much, Dr. Chacón. And for Dr. Arrieta and Dr. Cazap, do you have any figures and stats that you can provide us from your insight and or any input regarding the timelines? Yes, we have a project with NCCM, National Comprehensive Cancer Network in the United States for over 2 years, which is the entity with bigger dissemination indicating oncological treatments and the most recommended ones. And we reached to 3 key parameters that are necessary to evaluate. One is time. Two treatments that are done outside of the ideal times, surgical times, or medical treatment can be in reality very ineffective. The other is a medical indication to take in time the proper medical indications, and the other is if such indication is fulfilled by the patient within time and form, because one of the things we have some preliminary information is that only 30% of the doctors follow international regulations for a treatment indication. And so what we are seeing now that we need to do it with two databases, one in Argentina, another one in Colombia, one in Javeriana University, through our agreement, is if the patients with rightly indicated treatment fulfill and abide with the treatment in time, form, shape, and if they complete the treatment, because there are patients that don't do it. So these three parameters are key: time, in a medical indication, and correct execution of the treatment by the patient. So these are the key fundamental elements. Thank you so much, Dr. Cazap. And what about Mexico, Dr. Arrieta? Inside our institute, every functional unit, we have one for breast cancer, for thorax, for cervix, for sarcoma, for gastric matters. And so, yeah, every single unit has the indication to run their own timeline assessment involving the patients on an external fashion ever since we have the external diagnose, because we are an institution of referral. So the external diagnostics that it's done in the face of the pre-consultation from our institute. So this is how we take these parameters. And also from the pre-consultation to the first time, we measure these times. From the first time the person arrives to this functional unit to reduce the times in where we have a multidisciplinary meeting, medical meeting, and seriously the start of the treatment. And we are doing this to have a stable parameter regarding the patients. Of course, there are specific protocols that we are taking into account within the hospital, such as anxiety and depression of our patients, that may be also key and essential for these metrics regarding the aid and the help throughout the navigation for patients. A very important thing is that this navigation can be also, there is a first stage in the navigation of the patients, and that is done ever since the diagnosis when they reach the third level hospital. A very important part is the referral, the reference time. We have protocols of patients that we have a cancer code with several institutions in which we have a navigation system with social workers. And when we have the suspicion of such diagnosis, we refer them to a diagnosis center, and we have direct communication with such institute, and we measure the time that they take. And we are comparing this with the patients that we get from outside of the Código Cancer program. The objective is to reduce the timeline, but also analyzing our protocols, the stages and the differences between these code and those that come from outside of the program, and also the costs of attention to the patient. With these protocols, we pretend to generate public policies that prove the importance that investment has in patient navigation to reduce or improve the outcome and decrease costs. Thanks so much, Dr. Chacón, Dr. Cazap, and Dr. Arrieta, for being here, providing us with your own specific context and how navigation has evolved through the time. Thank you so much.
Bueno, Muchas gracias. Sabemos que hay
Thanks so much. We know that there are many questions. The topic drives us to all these doubts. Maybe we would like to be innovative, and this is our main goal in this Congress. We hope that we can set new networks for the future work that we have. There will be also different questions of those that you have that will be solved throughout the Congress, and we hope that this is the case. We invite now our arrangers, our speakers for the panel strategies for the implementation of navigation for patients within the region. We have Andriy, I hope I don't butcher your name, Chybisov, manager of a global support program for the American Cancer Society, and Jumara of the Foundation Bahia in Egypt. Welcome to Javeriana University. Please, can you indicate us if you need us to, will you handle your own slides, or if you need help, let us know.
Hello, it is very nice to be here, and I am sharing my slides. So can you confirm that you see that?
Yes, we can see.
Yes, okay, great, thank you. Good time of day to everyone, wherever you are. I think most of the Latin American continent are pretty much within our time, but I know that also participants from other regions have joined, so welcome to everyone. My name is Andriy Chybisov. I'm the program manager at the American Cancer Society's Global Patient Support Department, and I'm responsible for the organizational strengthening for cancer organizations, the work that American Cancer Society is doing globally. I'm also responsible for supporting the patient navigation community of global practitioners that is also known as the Beacon community that my colleague Jana has already talked about today, and that has been mentioned by several speakers here. And I'm here with Dr. Yomna Omara, Sharif Omara, and I'll give her the floor to introduce herself.
Hello, everyone. I hope you can hear me. And I'm really honored to be with you here today. And thank you for the ACS for the very warm invitation to join you in this conference. I am Yomna. I am a breast surgeon at Bahia Foundation in Egypt. Bahia Foundation is a foundation dedicated for early diagnosis and early detection and treatment of breast cancer. And I'm also patient navigation program manager at Bahia Foundation starting 2024. And I hope we share with you the information needed to strengthen patient navigation all over the world today. Thank you, Andriy.
Thank you. Okay, so it's a huge honor for us to be here today, and we will go through several elements of the patient navigation program that are required for a program to be effective and sustainable in the way that it is implemented. So today we would like to offer a framework for thinking about patient navigation program planning and implementation. We will also showcase how Bahia Foundation's patient navigation program has functioned, how it was designed, and how it reflects on some of the elements of this framework. And also we'll highlight certain Beacon Toolkit resources that might be useful or helpful for your patient navigation programs, whether you design the program or you are already implementing. We hope these tools will be helpful for you. So when discussing the strategies to implement patient navigation, there are many aspects that we can discuss. And the previous speakers, Dr. Cazap and Dr. Arrieta, have already mentioned some of those elements or aspects that the navigation programs require. Here we would like to kind of look at a different comprehensive framework for looking at patient navigation programs. The Navigation Sustainability Assessment Tool is a comprehensive tool that was developed by American Cancer Society under the Beacon Initiative. It is based on two tools, the Program Sustainability Assessment and Clinical Sustainability Assessment. Both of those tools were designed by the Washington University in St. Louis, and they consist of 26 measures around 5 domains. I'm not gonna name these domains now, but you'll see them here. The framework promotes continuous improvement and strategic planning, making it an essential resource for institutions aiming to embed navigation into their healthcare delivery systems. As we go through each domain, Dr. Yumna will cover how these aspects of patient navigation program have been implemented by Bahia's institution. I will hand it over to her now to talk a little bit more about the Bahia program before we move on to the details.
So at the Hair Foundation, we, as I told you, we dedicate our work and efforts to breast cancer only, and we have been putting this in our mission, the patient-centric approach towards the patient. So since Bahia started 10 years ago, we are celebrating 10 years this year. We have put the psychological support into the core of our patients' treatment, the breast cancer patients. So this has been evolving since then, since 2015, until we knew the Beacon Initiative in 2022 back. So we started getting the training, we accessed the toolkit, and we learned a lot. And since then, we have been evolving our program until we launched the very first patient navigation program in Egypt in 2024 with its full structure. This means that before Beacon and before 2024, we have had resource and physical navigation, but after 2024, we have also integrated the clinical navigation pillar to our patient navigation program, and it went from then. Back to you, Andriy.
Thank you. Okay, so let's start. As you start the design of your program, the first question to consider is how well the navigation program is integrated into your institution's strategic and operational framework. While a program can start as an add-on program, because of the very nature of patient navigation as a cross-cutting mechanism, but in order to break down the barriers for patients, this requires close coordination with all units within the health institution or cancer organization and beyond, going all the way deep into the community. And so Dr. Yumna will show how this aspect of mission alignment and integration has played out for Bahia.
The first thing that we did, so to be able to have a very successful patient navigation program at Bahia Foundation in Egypt, is that to embed the patient navigation services into the already existing healthcare system inside Bahia. So embedding the navigation services into the nursing roles, into the patient psychosocial support roles, into the patient relation roles, and integrating the workflows of the patient navigation services into the workflow of the patient. And we developed a hospital information system to track the navigation encounters and outcomes. And the program underwent strategic restructuring to unify all the clinical, resource, and navigation teams, fostering collaboration and shared identity. While these initiatives ensured that the navigation was not a standalone service, but a core component of Bahia's healthcare delivery, aligned with the institutional goals and supported by a robust data system, which is really, really important that we lack today. We need to have a lot of research. We still have to do more evidence-based research to standardize the patient navigation practices. So this is what we are trying to do, as long as we monitor and evaluate our teams and our encounters very well.
Thank you. Moving on to the next domain. Successful patient navigation programs deliver high-quality services that are responsive to the needs of the population they serve and the barriers to care they face. As patients' needs may change over time, programs should actively continue to assess the barriers to care and the priority needs and refine the activities as that need to be in order to be effective. And I'm kind of making a reference to the previous speakers who talked about the database and the results, and all of this data that we collect should eventually reflect on how we tweak the program in order to make it more patient-centered and more effective. Activities contribute to the achievement of goals and objectives, and really should demonstrate the program's value. All needed program components, such as program policies, tools, processes, systems, should be in place. Everything should be optimized to facilitate consistent and quality care delivery. Over to Yomna.
Yes, thank you, Andriy. Highlighting this is very important because this is how we evolve and how we expand. Finding out what is the problems with the patient, continuously assessing the barriers to care, and trying to find solutions to help them out. Like Andriy has chosen this amazing photo. The patients who keep losing their selves inside the healthcare hospital and navigating the healthcare complexities, having some small map with them so they can navigate in smooth way and walking around in a good way all around the hospital without getting lost, finding her way throughout physical navigations with her all the time. Also, assessing where should we expand. For example, before 2024, we have been offering navigation services to patients who are diagnosed with cancer only, but we expanded this program to include the patients who are visiting Bahia from the very first day, not only when they are diagnosed, but also on their very first visit. Not only this, but also having a call with them before they arrive to the hospital to feel a comfort, make her feel not just to make the fear vanish. Someone will be with her, someone will take away all the barriers and help her navigate the system. Back to you, Andriy.
Thank you, Yomna. The next domain looks at the staffing and resources. It relates to whether the program has adequate personnel that is adequately onboarded, retained, motivated, and supervised, and also supported, kind of going into those less formal ways of communication with staff and providing emotional support, being a role model for your staff. It also looks at the resources that our staffing has, whether those are adequate. And let's see how it plays out in Bahia's case.
So Bahia last year in 2024, we trained about 203 individuals, 203 individuals. This includes nurses, volunteers, managers. And we also used a flexible model of training. Instead of having people all day long in a training room, getting to know more about patient navigation, we decided to split the sessions into short repeated sessions to avoid any distraction, to avoid any interruption to the workflow. And the program expanded its volunteer base to meet an increased patient volume following the opening of our new hospital, because we do operate 2 hospitals in Egypt. And the training was structured and targeted, enhancing the team's capacity to deliver navigation services effectively. While these strategies ensured that the Bahia program remained resilient and scalable, and even during the periods of rapid growth, and highlighted the importance of continuous capacity building and resource optimization, which is really, really important. And this is something we need in the next few years to train and invest more in the personnel that will carry on patient navigation services in the hospitals. Back to you, Andriy.
Thank you. Moving on, this domain relates to the first domain that we talked about, but the first domain was more about integrating workflows and really being part of the strategy. This domain is about the people and the broad-based support that from all teams, including clinical team, administration, leadership, patient groups, civil society organizations, donors, international organizations, foundations, and so on. Is the program communicating well enough about its outcomes? Is it receptive to feedback internally and externally? And let's see how this plays out in Bahia's case.
So very important is to measure the impact of the program throughout the patients. So we created a survey, a satisfaction survey with over 1,400 patients to gather their feedback on the navigation services. And we have found a very, very positive feedback. And also we have found a drop in the percentage of patients who missed their appointments because they were contacted and they were actively being asked about their barriers, and we solved these barriers. So in order to make this happen, we collaborated with international organizations as the World Health Organizations and of course the American Cancer Society and the Beacon Initiative, and as well as the Swedish Cancer Society. And our program is gaining a global recognition. These efforts are demonstrated strong internal and external support. So with patients expressing their appreciation for the educational sessions that the clinical navigators give and the guidance that the physical and resource navigators give to them. The stakeholders' buy-in was critical so that Bahia succeed and to enable the program and to influence the national standards and maintain the high levels of patient trust and engagement.
Thank you. The next domain talks about financial planning and funding stability. There are two components here. There is a component of generating resources for the program, and there is also a component of making sure that the resources are used effectively, efficiently, and are not overutilized, because the dollar saved, the dollar earned, right? That's what they say, I think. So making sure that we not only think about resource mobilization when funds run out, but we should continue to think about the whole cycle and how do we plan proposals, how do we engage with donors from the very beginning, at what time do we make the ask. All of these aspects are critical for the program functioning. Over to Yona.
Yeah, Bahia successfully included the patient navigation program expenses in 2025 budget, and we continuously doing this over the next few years. This is supported by donor contributions, as Bahia Foundation is an NGO. Also, the health information system module that enabled data-driven reporting, which was used to justify the funding and demonstrate the program impact. And the strategic financial planning ensured that Bahia could sustain its services beyond the grant period that we thankfully had from the American Cancer Society last year. So all these practices highlight the importance of integrating patient navigation into institutional financial systems and using evidence to support resource mobilization and long-term sustainability.
Wonderful, thank you. So just as we are going through the last three slides, this is an introduction to the Beacon Toolkit. It has three parts. It has the theoretical part that we all should be on the same page about when it comes to what cancer is, what are the methods for treatment, and so on. The second phase is all about designing and launching your program. It's about how it provides all the tools that are necessary for determining staffing needs, writing SOPs, hiring and retaining staff, and so on. And the third phase is about implementing and learning from your implementation, learning from the data. I will just mention a couple of resources that are included in the Beacon Toolkit just as examples. The first one is dedicated to the needs assessment that should be conducted in order to plan the program. We have an activity 2D that provides this and many other tools that enable you to conduct your needs assessment. You don't have to reinvent the bicycle here. The next activity helps you to map the services available to patients outside the facility. I mentioned that any services should be linked back to the community. So this tool helps us in doing that. The next activity is part of section 3, and it guides us through developing the program vision. Finally, the section 4 activity and activities within it support you through moving from vision to a specific program design and specific activities. There are many, over 100 activities in the toolkit, and we invite you to let us know if you would like to know more about it and join the Beacon community. Here is the email address you can write to. Thank you so much. It was short, but we really appreciate the opportunity to present to you today.
Thank you, everyone.
Muchas gracias, licenciado Andriy, doctora Yoma. Invitamos
Thanks
al
so much,
doctor
Andriy and Yoma. We invite Dr. Eduardo Cazap. Please be efficient with time, doctor.
Sí, cómo no.
Yes.
Yo creo que
I
me
believe
parece que dentro
that
del contexto
inside
de lo que se
the
ha
context of
presentado,
what
habría
it's been presented,
dos
there would
preguntas
be two key
que me
questions
parece podrían
that I
ser
believe
útiles
that
para
could be useful
facilitar una
to
conversación. La
facilitate
próxima, por favor.
our conversation, our discussion. Next, please.
¿Cuáles serían, al entender de cada uno, las dos
From your
estrategias
point of view, what would be the two priority strategies for the implementation of patient navigations in Latin America? I think that would be the question that we had for the panel.
Yo pensé cuáles
And
serían
I thought what would be,
y elegí dos. La próxima, por
and I
favor.
chose the two.
Creo que es
I
el
believe that
establecimiento de un marco legal y
it's establishing
financiero
legal and
a través de
financial
una
framework
política pública
through
central
a central public policy
con dos componentes. ¿Por qué?
with
Porque
two
como
components.
estuvimos conversando
Because as we
previamente,
were talking
dentro del contexto de América
previously,
Latina, la
within
falta de
the
un marco
context
legal,
of Latin America, the
como
lack of a
observaba
legal framework
en preguntas
in
anteriores, es un
prior
limitante
questions,
muy importante,
it's
pues
very
en muchos de
important
nuestros
limiting
países
because
el
in many of
sistema
our
público del
countries,
gobierno
the
es el
public
sistema prevalente
government
entre la
system is the
población.
prevalence system in
Y
populations.
entonces
And then
hay dos puntos. La principal
there are
barrera
2
es
points. The main
falta de
barrier
sostenibilidad y el
is
carácter
lack of
fragmentado de los
sustainability and the
programas
fragmented
que
nature
a
of
menudo
programs
dependen de
that
iniciativas
sometimes
aisladas,
rely
ONGs,
on
hospitales
isolated
piloto, etcétera,
initiatives, NGOs,
o
pilot
dentro
hospitals,
de alguna
etc., or
estrategia nacional, como
within
puede
some
ser el Plan
national
Nacional de
strategy,
Cáncer,
as a
si
national
no
cancer
está la
plan,
navegación dentro
if
de la
we don't
política
have navigation
pública y
within the
con su
public policy
correspondiente
and
presupuesto,
with the corresponding
no provee una buena
budget
implementación.
does not provide for good
Entonces, creemos
implementation.
que
So
desde
we
nuestro
believe that
entender
from
para la
our
región, la
understanding for the
estrategia
region,
prioritaria es elevar la
the
navegación de
priority
pacientes
strategy
a
is
la
raising
categoría de un
patient
servicio
navigation
esencial dentro del
to the
sistema de
category of
salud
an
a
essential
través de
service within
políticas
the health system
públicas y
through public
legislación.
policies and
Esa sería,
legislation.
digamos,
So
la
that
próxima,
would
por
be
favor.
our contribution,
Nuestro comentario, para lo cual
our comment,
necesitamos
for
una
which
interoperabilidad
we need
digital y tecnológica,
digital and
porque si
technological
realmente los
interoperability.
sistemas públicos
Because if
no
actually the
saben qué
public
sucede dentro de
system
cada
don't
uno
know
de
what
los
happens within each
estamentos,
one of
es muy
the
difícil organizar las
entities, and it's
cosas.
very hard to
Para
organize the
lo cual
things. So
habría que poner como
we
función central del
should
navegador de
add as a
pacientes como
key
un
function of
eliminador
patient
de las
navigator
barreras logísticas y
as
de la
an
información,
eliminator of the
y
logistic and
habría que avanzar
information
en
barriers.
políticas que
And
obliguen
we
a
will need to make progress in
interoperabilidad de
policies that
información
force
sanitaria
to
desde
the
historia
a
clínica
clarity
hasta lo
of
que sucede
or
en
to the
atención
interoperability of
primaria,
health
lo que
information
va a un hospital de
from the
referencia o lo que va
primary
a un hospital de
healthcare to reference
especialidad.
hospital to
Porque
specialty
si el
hospitals.
sistema no está
Because if
integrado,
the system is not
es poco probable que
integrated,
tengamos ahora
it's very
un
unlikely that we will
resultado
have now
positivo.
a positive
La
result.
última. Me parece que en base a esto
I
sería
think
muy
that
bueno
based on this, it would
escuchar
be
las opiniones
very good to
de los
hear
demás expertos. Muchas
the
gracias.
opinions from the other experts. Thank you very much.
Muchas gracias, doctor Cazap.
Thank you, Dr. Cazap. We invite now Nurse Rosa Victoria Castañeda. She is oncology nurse at Javeriana University, and she is here with us today.
Bueno, pues ya hemos repetido.
We have repeated some topics. Good morning. Well, it's not repeating, but enunciating, but strategies for implementation of patient navigation in LATAM. And the question is, and what strategy is required for the implementation of a navigation program in Latin America? And you have talked about the context. If we are going to talk about Latin America, as it says there are differences in the health system in Latin America. Are there differences? Yes, there are different variable levels of coverage, urban, rural gaps, and social challenges, and even there are linguistic and population problems. Yes, if we talk about cancer, for example, in Colombia is located in the main cities of the country. If we talk about radiotherapy and else, they are in the main cities. So in that context, I established some strategies that somehow have been initiated during the conferences, lectures, strengthening education and training of health professionals. Definitely when they talk about information of clinical navigations, because we need to be speaking the same language. We need for psychologists to understand what is patient navigation, social work needs to understand what patient navigation, doctors, nurses. If there is not a good articulation, that thing that is so beautiful that we reflect as going through the health system without one of the problems is adherence to the health system is one of the biggest problems, definitely. And we talk about cancer, situation is complicated. So implementing programs, but even when we talk about implementing training programs, it's that they should be well structured. We need to get to know the legislation, we need to go the ethics, and also something that would be mentioned, and it's two different elements. What do we do in oncology? Chemotherapy, radiotherapy. So education is important. So integration of navigation to the health system. Definitely, we do need to know how our health system works to be able to integrate navigation. The navigator needs to be pretty much with the entire health team, and they need to play the role that they should actually play. So when we talk about competence, is that they do or that they play the role that they should play. So somebody asked about this at the primary, secondary, and tertiary level. There needs to be articulation. In strategy number 3, community participation, culturally relevant. And see, check it that when you go and you carry out studies in the different regions of the country, because this also is in like agreement of wills, and that is an important aspect, and it's research. Research, why? Because Latin America right now is going through a transition process. Navigation has come as a new model that wants to show us another thing, different things. So that is a better healthcare. Community leaders in and local networks in program design, adapting the language and the communication methods to the linguistic and cultural context. And inclusion. Nowadays, we talk about inclusion, a lot of patients, indigenous and other communities. Designing educational materials appropriate for the literacy level of the patient. The strategy number, institutional and political support. Definitely this needs to be included in that part of public policy. Included navigation in local and national health policies. See how important it is to seek for public funding. And nowadays, today, we cannot and recognize, for example, NGOs, volunteers, and else, because they all should be around supporting navigation. Make use take advantage of technology that was already mentioned, something that pretty much we are all around that. We talked today about telemedicine, we talk about nursing, and how do we connect all this information. Digital systems for the follow-up of patients, appointment management and coordinator amongst levels. There are issues that appear even because today, get the appointment by phone. And sometimes you realize that people definitely get tired because it takes them 2 or 3 hours trying to talk, trying to get through to get the appointment. And that navigator, we have then a positive impact. Monitoring and evaluating the efficacy of the navigation programs that has also been mentioned in the different talks, where it says we need to establish those indicators. Francisco mentioned that. So we do need to have clear statistics and we need to have very good databases so that we can present them and obtain or get the information that is necessary to actually see the impact that is generated. Gathering patient feedback and staff feedback to adjust the program, because this is dynamics. We are checking what is it that we need to improve, etc. What needs to be changed. And well, the key considerations for success in Latin America: adaptability, and definitely, if I want to talk about Latin America, we need to talk about each one of the countries that they have a way to manage the health level. So each country has its own health system, sustainability, looking for the support of the government, private sector, international cooperation. This would be wonderful if we could do something like the one that you see. Everything is for real, and we had something like, well, I am an oncologist, and I have been for quite a few years in the oncological areas. And look, I had one slide that says we all united for cancer because cancer is my thing. Equity, prioritizing patients in situation of vulnerability, rural areas, poverty, minorities, and else. In here, navigation does have a lot to do and having a positive impact in patients' adherence. And well, and now to end, patient navigation needs to be a comprehensive process that goes beyond reference and considers education, the social context, regulatory frameworks, and the technology. Those strategies need to be adapted in terms of development of every country, but with this collaborative regional approach. So the support is the one that needs to be.
La frase célebre de la navegación de
ending
pacientes
with this famous sentence: patients navigation is not a luxury, it's a key, it's essential strategy to guarantee equal, continued, and human access to healthcare in Latin America. Thank you very much.
Muchas gracias, Rosa Victoria.
Thank you very much, Rosa Victoria. So now we invite Viviana Rivera Lozano. She's a representative of the Foundation United Against Cancer in Costa Rica. Welcome.
Bueno, buenas tardes. Es un gusto para mí estar
good afternoon.
con ustedes y
For
hablando
me,
específicamente
it's
sobre una estrategia que se está utilizando en Costa Rica.
very important to talk about a strategy that is patient navigation through a volunteer.
Como mencionaban, mi
As
nombre es
I
Viviana,
mentioned, my name is Viviana, and I am the coordinator of the patient navigation program of United Against Cancer.
Nosotros somos una
We
organización de pacientes
are a patient organization,
comenzó en el
nonprofit,
2012.
that started out in 2012. For 2019, we started with the patient navigation system. We navigate patients from the hemato-oncology department in the Mexico hospital, which is a third-level hospital, a national hospital. Right now, we have a binding relationship with this department, where doctors of this department refer patients to us so that we can support and approach different barriers identified. And when we identify a barrier that is being faced by the patient and the solution is in our hands, so we work jointly to solve.
El proyecto busca
The project
reducir las
aims
barreras
at reducing the barriers in the healthcare
Actualmente
process.
contamos
Right
con
now,
más de 40 navegadoras de
we have
pacientes
more
que
than
ofrecen
40
sus servicios
patients
de manera
navigator that
voluntaria,
offer
es
volunteer
decir, no
services,
reciben ningún pago económico por sus
so
servicios.
they don't
La
get any
mayoría
economic
son
payment for the benefits.
mujeres
Most of
que
them are
han
women
superado el
that
cáncer
have overcome
o
cancer
familiares de algún
or
paciente que también ha
relatives
pasado
of
por
some
esta
patient that
situación.
also have gone through that situation.
Algunas de las funciones que cumplen
Some of
las
the
navegadoras de
functions,
pacientes voluntarias en este proyecto
roles
es
played by those
guiar
navigators,
a
volunteer
pacientes
navigators in
en
that
sus
project is
trámites en
guiding
el
patients
hospital,
in the
también realizar
processes in the
trámites
hospital,
rápidos para evitar
also
que el
fast
paciente se
processes
dirija
to
hasta el
avoid
hospital, por
for the
ejemplo,
patient to
para
go
el
to the
servicio
hospital.
de
For example,
radiología, el paciente
for
debe presentar
radiology
una
services, the
referencia
patient needs
impresa
to have
para que le
this
den la primera
press
cita
reference so
y
that
al
they get
día
the first
siguiente
appointment,
deben
and on the
retornarlo
next day they need
para que le
to
den el día y la hora de la primera cita.
go and get it so
Ese es
that
un
they
trámite
get
que
the
se
first
hace
day
muy
and time
rápido.
of the first appointment.
Hay
That is a
pacientes que tienen que
fast process,
trasladarse 5
but there are
horas hasta el
patients that have
hospital
actually
para
to move
pedir
5
la
hours to the
fecha
hospital
de la cita.
so that they get
Y de
the
una
date of the
manera
appointment. And with the
facilita y
navigator,
se evita que
it's
el
easier,
paciente
and
vaya
we
hasta el
prevent the
hospital.
patient from going
También
to the
se
hospital.
acompañan a pacientes en citas médicas y
Also,
aplicación de
there's
tratamiento cuando el
accompaniment
paciente
in
va solo
patients
al
to the
hospital
doctor
y
appointments
desea
or
tener
some
esta
tests
etapa
when
llamada.
patients go by
Las
themselves
navegadoras
and they
también
require
refieren
that
pacientes
accompaniment.
a la
Navigators
coordinadora
also
del
refer
proyecto
patients to
cuando
the
se
project
identifica alguna
coordinator
barrera
when
para
some
su
barrier
posterior
is
abordaje.
identified for later
También
approach.
recolectan datos
They
con fines
also gather
estadísticos y de
data with
investigación
statistical
y
and
también
research
efectúan
purposes, and they
seguimientos
also carry
telefónicos
out
a los pacientes con el fin
telephone
de
follow-up to the
identificar
patients in
nuevas
order to
barreras
identify new
que
barriers
vayan enfrentando
that
en el
they
proceso de
might
atención.
face in the healthcare process.
Algunas de las barreras
Some
más
of the
frecuentes
most
que se
frequent
abordan desde el
barriers that
proyecto
are approached from the
son
project
para la categoría de las
are
barreras
for the
prácticas,
category
el
of
transporte.
practical
Para
barriers,
esta barrera tenemos un
transportation. For
convenio
that
con
barrier,
Uber
we
por
have
medio del cual
an agreement
los
with
pacientes
Uber,
pueden
where the
solicitar el
patients
servicio
can request
sin que se le
an
cobre
Uber
directamente al
without
paciente.
being
Es decir, no
directly
implica un
charged
gasto
themselves.
económico para ellos.
So they don't have to
Esto
pay
es sumamente
themselves.
importante
So
para los
that's an
pacientes
important
de bajos
moment for
recursos
the
que tienen que
patients with low
trasladarse hasta
income
el hospital
that
todos
have to
los
go to
días
the
para
hospital
recibir radioterapia.
every day to get
En cuanto
radiotherapy.
al acceso a alimentos,
About the
contamos también
access
con un
to
convenio en
food,
el
we
hospital
also have
para
this
ofrecer tiquetes para el
agreement in the
desayuno,
hospital to
café,
give
almuerzo y cena para los
food stamps,
pacientes
like
de bajos
for
recursos que
breakfast
tienen que
or
pasar
lunch or
las
dinner
6 horas
for
en el
low-income patients
hospital.
that have
Y
to
también tenemos un programa que se llama
be
Pan de Amor,
all
que
day. And we have
consiste
another
en
program
entregar
where
productos,
we
alimentos y de
give
cuidado personal
food
y
and
limpieza para que lleguen al
cleaning
hogar. En cuanto al
elements,
alojamiento, hay
food
pacientes
kits
de
or
zonas costeras que
hygiene
están
kits
alejadas de la
for
capital
other
y
communities that
requieren
are
un
distant
lugar
from
para
the capital
instalarse
and
cerca
need
del
accommodation
hospital.
near the hospital.
Igualmente,
We
especialmente para
also
la aplicación de
provide that
radioterapia, que son
support.
todos los días.
For example, for
Para
those
eso
patients that need
tenemos
radiotherapy,
el servicio que es
so we have
gestionar un
that
albergue,
service
ya
that is
sea el del hospital
managing
u otro
accommodation,
que
whether
pueda
in the
recibir al
hospital or
paciente y a
another
un
one,
familiar
so that
para
that
que
it can
puedan
host the
estar más
patient and
cómodos y más
maybe a
cerca del
family member,
hospital.
so that they can be
En
comfortable
cuanto a
and
las
closer
barreras
to the hospital.
psicológicas, específicamente
About
por lo social,
psychological barriers, in
ofrecemos el
particular,
acompañamiento a
we
citas
offer
y
the
a trámites,
support,
que fue lo que
the
mencioné como
accompaniment
parte
to
de las
appointments
funciones.
and
Y
processes.
en cuanto a
That
las
is,
barreras
as
del
I mentioned,
sistema,
and about the system
específicamente
barriers,
largos tiempos
specifically
de espera y
long
citas en
waiting
puntos
times
inconvenientes,
and
las navegadoras
appointments in
de
inconvenient
pacientes
times. The
en el
patient
hospital
navigators in the
tratan
hospital
de
try
adelantar las fechas
to
según la disponibilidad
move the
o
dates ahead
cambiar las
according to the
citas por un
availability
horario
or
más
changing the
conveniente
dates
para el
to a more
paciente.
convenient time for the patient.
Para mencionar algunos de los
To
resultados que hemos
mention
obtenido hasta
some
el
of the
momento,
results
hemos
that we have
captado a más de
obtained so
850
far, we have captured
pacientes,
more than
hemos
850 patients.
realizado
We have carried out
1.842 trámites, se han
1,842
realizado también 323
processes
acompañamientos en
or
citas y
errands
154 visitas
and
hospitalarias.
more than
Estas visitas
323 accompaniment in
hospitalarias
appointments,
especialmente es
154
para
hospital visits. Those are the
mujeres con
hospital
cáncer de
visits
mama
is
que son
usually for women
operadas, que están
with breast cancer
internadas
just
y las
operated
navegadoras
on,
las visitan en
and
la cama
navigators visit them
para
on the
ver
bed
cómo se
to
encuentran,
check
si
their
hay algo en lo que
condition, if
podamos
there's something
ayudar.
that they might need.
Incluso muchos
even a lot of family members, when they lost communications with the patients, they ask for our help so that they can have better peace of mind and for the patient not to feel also by themselves.
¿Cuáles son los beneficios de incluir
What are the
voluntarios en un
benefits
proyecto de
of
navegación
including
espacial?
volunteers?
Son parte de la
Um,
comunidad por lo que conocen la cultura y la
They are
realidad
members of
social
the
del
community
paciente.
because they know about the
Generan
culture,
relaciones
the
cercanas y horizontales,
social reality of
al
the
no ser,
patients
un
that are
navegador clínico, maneja el
close
mismo lenguaje del
horizontal
paciente,
relationships. They also
también se
manage the
crea como un
same language
espacio
of the
de
patient.
empatía al ya
There
haber
is
atravesado por la
the
misma
generation of
situación
this kind of
o haber
empathy
acompañado a
sometimes
algún familiar
by
por todo este
probably
proceso de
having
atención.
being close
También
to
promueve liderazgo local
some
en
family member or
colaboraciones
having gone through
comunitarias
that. It
y
also
es un proyecto
promotes
de bajo
local
costo,
leadership and it's a
donde la
low-cost
inversión que se requiere sería la
project where the
capacitación, la
investment required
logística
is the
y la
training,
motivación
logistics,
de las
and
voluntarias.
motivation of
Sobre este tema
volunteers.
de la motivación,
About
me
that
gustaría
aspect of
mencionar que
motivation, I
nuestro
would like to
porcentaje
mention
de
that our
retención de
percentage
las personas
retention of
voluntarias
the
es
people,
de
volunteers, is
71%.
71%.
Creemos que la motivación es
We
un factor
believe that
crucial para
motivation is the
mantener a las
key
voluntarias en el
factor
proyecto
to
y
keep
también,
the
¿verdad?, para
volunteers in
cumplir
the
con los
project
protocolos
and
y
also to meet with
todos los
the
estándares
protocols
establecidos.
and all the standards established.
Como son personas
Since
voluntarias,
they
no
are
tienen esta
volunteers,
formación
they
clínica,
don't
por lo
have that
tanto, tienen que pasar
clinical
por un
training.
proceso de
Therefore,
reclutamiento
they
y
have to go through a
capacitación
training
lo más
process
riguroso posible.
as rigorous as
Lo que
possible.
hacemos,
So what we
lo que
do
hacemos es, primero, se abre la
is
convocatoria,
first
donde
we
se publica que
opened
están
for the invite where we
aceptando
published that
personas para el voluntariado.
people are being
Luego,
accepted
las
to the
personas que
volunteer.
muestran interés,
Then the people that show
lo que se
interest,
hace es aplicar criterios
what
de
they do
inclusión, que
is
sería ser mayor
apply
de 18 años,
inclusion
tener
criteria,
compromiso y
being over
empatía,
18, having
tener
commitment and
disponibilidad para la
empathy,
capacitación,
availability for
posteriormente para el
training,
voluntariado.
and also for the
Luego de esto se
volunteer.
aplican
After
entrevistas a las
this,
personas
the
interesadas para saber por
interested
qué desean ser
people are
voluntarios
interviewed
y
to know
también
why
se
they want to be
plantean
volunteers,
algunos análisis de
and also
casos
some
para
case
ver
analysis are
cómo
presented to see
reaccionaría
how
la
the
persona ante situaciones
person would react
cotidianas
in
que
face of
enfrentan las
everyday
navegadoras de
situations that the
pacientes.
patient navigators face.
Luego se da la
Then
capacitación, que es virtual, para tratar de
there is
llegar a más
online
cantidad de
training to try
personas
to reach
que
more
puedan
people
verlo a la hora
so that they can
que más
see
le
it
convenga.
at the most
Y
convenient time.
los temas
And
que se
the
brindan son principios de navegación de
aspects are
pacientes, principios
patient navigation
éticos,
principles,
captación
ethical
de pacientes,
principles,
soporte
patient capturing,
emocional
emotional
y
support,
generalidades de las
and
patologías
generalities of the
hemato-oncológicas.
oncological
Estos temas
generalities.
son
These
brindados
topics
tanto como
are
parte
provided both as
de
part of the
la Asociación Unidos contra el Cáncer como por
Association United
médicos
Against Cancer,
del Departamento
as
de
well as by doctors
Hemato-Oncología del
from the
hospital.
Hemato-Oncology
Luego
department in
de
the
eso se
hospital.
realiza un
After
examen
that,
teórico que deben
there is a
aprobar con una
theoretical
nota mayor
exam
a
that needs to
70
be approved
y
with a
se
grade
procede
over than
luego a
70,
una práctica
and
supervisada
then we go to a
que tenga una
supervised
duración de
practice
4
with
semanas
this duration
y
of
las
4 weeks.
navegadoras con
And
experiencia
navigations
son
with
las que se
experience
convierten en
are the ones
instructoras
that
para que
become
las
instructors
navegadoras
so
practicantes
that the
logren ver cómo es la
practicing
dinámica
navigators
día a día en el hospital.
can see
Luego de eso
the
se procede a la
everyday
graduación, se entrega
dynamics in the
un
hospital. Then
certificado
there
de
is the graduation.
participación
They are given a
y ya
participation
podrían
certificate,
estar en el hospital
and
ya
then they
navegando
could be in the
pacientes.
hospital
Y luego de
navigating
esto se
patients.
da una
And
capacitación
after this,
continua
they
para
get a
actualizar
continued training
conocimientos y
to
para aprender
update
conocimientos.
knowledge and to learn new things.
Me gustaría
I
cerrar
would like to
la
close
charla
with the
mencionando
talk
algunas
by
de las frases de
mentioning
las
some of
navegadoras
the
cuando yo les pregunté
sentences
por
from
qué brindan sus
navigators when I
servicios
ask them, why do
voluntariamente
you
sin
provide
recibir
your
nada a
services
cambio para
voluntarily
ayudar a
without
los
getting nothing
pacientes
in
en el
return
hospital. Por
to
eso
help
me
patients in the
gustaría
hospital? So I
leer
would
las
like to read
respuestas de algunas de
some of
ellas.
their responses.
Entonces,
So,
una sobreviviente de cáncer de mama mencionaba, soy
breast cancer
sobreviviente de
survivor
cáncer de
said, I
mama,
am a breast
sé lo que
cancer
es pasar por
survivor.
esta prueba
I
tan
know
dura.
what it is
Otra
to go
navegadora
through
decía,
this
quiero
test.
aportar un granito de
Another
arena porque
navigator
tengo
says, I
leucemia.
want to contribute
Es una forma de agradecer a Dios y
because
al
I had
hospital.
leukemia.
Eso lo
It's a way to
mencionó
thank
una
God and the
sobreviviente de
hospital.
cáncer de estómago. Por gratitud. Eso lo
So
mencionó
this was
una
mentioned also
sobreviviente de
by
cáncer de mama.
a breast cancer
Después de haber
survivor.
pasado por cáncer
After
de
having
mama,
gone through
he
breast cancer,
comprendido lo
I
importante
have
que es
understood
sentirse
how
acompañado.
important it
Es
is to feel
importante el
accompanied.
acompañamiento y seguimiento que podemos
Accompaniment
brindar
and
desde
follow-up
el
that
voluntariado.
we can
Con
provide
la
from the
frase de
volunteer is
estas
really important.
voluntarias me despido
With the phrase of this
y
volunteer,
muchas gracias por
then
su atención.
I say goodbye and thank you very much for your attention.
Agradecemos a Viviana y la invitamos a
Thank
la
you,
mesa.
Viviana.
Vamos a tener como moderadora
So
de
we will have now the
este
moderator of
conversatorio a
this
la licenciada
conversatory to
Minerva, que ya nos ha
Minerva,
acompañado
that
también
she has joined us
durante
also
esta
during
mañana
this.
y va a
She
estar
was
con
with us this
nosotros
morning, and she will be with us in all the event. Licenciada Guillón will moderate the panel. If you have any question, also to be able to pass the mic.
o en Teams. Adelante.
Or
doña
via Teams. Go ahead.
Tenemos las preguntas.
While you have the questions.
Acá tenemos una pregunta.
Gracias. Es una pregunta para la profesora Rosa
Thank you very
Victoria.
much. It's a question for Professor Rosa Victoria Castañeda. I really liked to see the context, and particularly for the Colombian case, I wanted to know if within the experience that you have been carrying out, have you been able to integrate navigability strategies, community, with institutional strategies?
Muchísimas gracias, muy amable.
Thank you very much.
Bueno, pues
Well,
nosotros,
we,
yo no comencé contándoles
well, I
que,
didn't start by telling you
curso de NP
that
como navegador
I
de
took the
pacientes.
MPI
Esa
course,
alianza
and
también
we
y a
started that
trabajarlo,
Alliance, a
casi
special
que
navigator, and we
ustedes
started
vieron
to
que
work.
casi se contaron
You see
varias
that
experiencias.
different experiences were
Nosotros, yo trabajé en
shared.
el Instituto
I
Nacional
worked
de
in the National
Cancerología
Cancer Institute
también como
also,
docente de la Javeriana,
and as a
y
teacher of
esa
Javeriana, and
articulación
that
está,
articulation
o sea,
is
la hemos
the,
pensado,
we
la
have
hemos
thought about
proyectado,
that, we
pero
have
todavía
projected that,
completamente
uh,
estructurado en
you know,
estos
in having
momentos.
something
Sí se
so,
está
I mean,
pensando
we don't have something so
definitivamente
structured right
que
now.
debe
We
haber
are thinking
una
that we need to have
articulación a nivel
articulation
primario,
at the
secundario y
primary,
terciario.
secondary, and tertiary level.
Muchas gracias.
Thank you very much.
¿Hay alguna otra pregunta?
Is there any other
Sí,
question?
hay una
Yes, there is a
pregunta
question
desde la industria
in the streaming
farmacéutica, el
from
programa
the
de soporte a
pharmaceutical industry,
pacientes.
the patient
¿Qué
support
habilidades debe
programs.
tener el equipo para
What
abordar
skills
pacientes para
should the patient
facilitar la
have to be
implementación
able
de
to
la navegación?
facilitate implementation of
¿Quién puede contestar la pregunta?
navigation? Who can answer the question, please? Some of the presenters.
Sí, mientras lo van pensando, yo soy la presidenta de la
While you
Asociación de
think, I am the president of the Oncological
y nosotros tenemos un
Nursing
nexo fuerte con
Association,
la industria
and we had a
porque
strong
realmente la
connection with the
industria
industry because
apoya
actually
a
the
las
industry
asociaciones
supports
científicas.
scientific associations
Entonces,
in our
desde
country.
ahí
So
hay una parte bien
there
importante
is
que
an
es el tema
important part
de
from that,
adherencia
that
y
is
en
the aspect
eso
of
la industria
adherence, and the
farmacéutica juega un papel
pharmaceutical industry
fundamental
plays
porque
an
nos
important
apoya
role
con el
because they
tema de
support
la
us with the
innovación,
aspect of
del
education,
conocimiento y demás,
knowledge,
que
and
hace que
else.
de alguna manera
That makes
nosotros
that
que
we
nos formamos, que
that
estamos
we are trained,
capacitándonos a diario
that we
también,
are
podamos
educating
cuidar
ourselves every
nuestros
day, we can
pacientes.
take
Hoy
care of
por
our
hoy
patients.
existen varios modelos en Colombia.
Today in
Lo voy a
Colombia,
mezclar. El
we have
modelo,
different
está el modelo gestor
models.
del que
We
también
have
hablaba creo que el
the
doctor
model
Juan
that is called
México.
like manager,
Nosotros también lo
gestor,
tenemos aquí, y el modelo navegador.
and
Que
the
lo que busca es que
navigator
de alguna manera nosotros
project.
podamos hacer un seguimiento
But the
muy
objective
juicioso y muy
is to
responsable
follow
a
up
los pacientes oncológicos,
oncological
sobre
patients,
todo porque ustedes saben que los
especially
tratamientos
because you
son
know that the
muy
treatments
largos,
are
muy agresivos y demás,
long,
y que los
aggressive,
podamos
and
acompañar
else,
casi
so
hasta el
that
final,
we
como
need
alguien lo
to
mencionaba,
be with
hasta
them
cuidado
almost
paliativo.
until the
Y
end.
hoy por hoy en Colombia
And
tenemos un
nowadays
mismo
in
modelo
Colombia,
que
we
nos
have also
está
something
uniendo
very nice that
los
we
sobrevivientes
can
del
see,
cáncer, que
and
no
is
los podemos dejar de
cancer
lado, ¿no?
survivors that they cannot be left aside.
Gracias, licenciada
Thank you very
Castañeda.
much.
¿Alguien más quiere
Anybody
contestar
else
la pregunta?
wants to answer the question?
Si no es así, yo tengo una pregunta
If it's not,
personalmente para
I
la
have
doctora,
a personal
para la
question
licenciada Rosa Victoria
for
Castañeda.
Doctora Castañeda.
¿Cómo
That is,
derribamos las
how
barreras
do we throw
tecnológicas a los
down the
pacientes,
technological
en
barriers?
especial a
How do
nuestros
we overcome the
envejecientes,
technological
con
barriers
tanta
for
dificultad a veces?
barriers, especially for elderly patients?
Es una muy buena pregunta.
It's a very good
Pero
question,
mire que
but
de pronto, dentro de los mitos que
maybe
uno
as part
tiene,
of the myths
es que
that you have
los
is that
adultos
the
mayores de pronto son más demorados
elderly people
en
probably
comenzar
they
a
take a
aprender la
little longer
tecnología y
in
demás.
learning about how to
Nosotros
use the
cómo hemos
technology
encontrado
because we
realmente,
have actually
sí nos hemos
realized that
podido
we
comunicar
have been able
con
to
las áreas
communicate
rurales.
with the
Por
rural
ejemplo,
areas. Of
hay
course,
ciertas regiones en
there are
donde
certain
la
regions
internet sí no
where
es
internet
como lo
is
mejor,
not the
pero
best,
sin embargo
but
tuvimos una
we had
experiencia
an
que fue
experience that was
en Hondoto, en el Chocó, que
in
es
the
una
Pacific
zona
area,
aislada,
very
pues
isolated
bien
area of Colombia,
aislada, rural,
rural,
con escaso recurso
with
económico,
a very poor area, and they had a central internet point, they had a booth, and there is always people that helps them, and also the navigators also play this role of education. We have clinical and non-clinical navigators, right? And that's why also the training process needs to happen to support them, but they can do it.
Muchas gracias. ¿Hay alguna otra pregunta?
Thank you.
No,
Any
no
other
tenemos.
question?
En el público tenemos. Sí. Gracias. Adelante.
Yes, thank you. Go ahead.
Hola, muy buenos
Hi.
días. Durante las exposiciones que
During
están
the
haciendo ahorita,
presentations, we have seen
han
that
hablado sobre
you have
la
talked
importancia
about
de
the
conseguir la
importance of
financiación desde
getting
fuentes públicas y a
funding
través
from
de
public
donaciones.
sources
Sin
through
embargo, también
donations.
se ha visto
However,
experiencias documentadas
there
donde
have
la
also been
estrategia de
documented
navegación
experiences
es
where
un
the
ejercicio que
navigation
ha
strategy
demostrado
is an
ser
exercise that has proven to
autosostenible
be
porque
self-sustainable
genera o
because it
evita
generates
desperdicios
or
en salud
avoids
o porque
wastes
aumenta los
or
ingresos de los
increases
prestadores.
the
Y yo
revenue
quisiera
in the
hacerles
suppliers.
dos preguntas. La primera es, ¿qué
So there are two questions. The
recomendaciones
first one
ustedes
is, what
harían, nos
recommendations
harían
would you make
para saber qué elementos
to know
considerar
what
en
elements to consider
acompañarlos como
in
sistema a los diferentes
supporting
actores
each
para
other as the system in
demostrar
the different
que las
actors to
estrategias de
prove
navegación
that the
también es una
navigation
inversión
strategies
económica que
is
vale la
also
pena
an
hacer?
economic investment that is
Y por
worth.
otro lado
And
también,
on the
¿cómo
other
ha
hand,
sido su experiencia
what about
dentro
your
de las
experience
estrategias que
within the
ustedes
strategies
manejan
you manage to
con respecto a eso?
about that?
¿Alguien puede, por favor,
Can
contestar la
anybody
pregunta?
answer the question?
Los que están en línea. Ah,
Hello again. It's Yomna.
go ahead.
Yeah, thank you. Well, I think I have two things to mention for this question. First of all, about the sustainability and the funding. One of the greatest things that we have at Bahia Foundation, and maybe it's one of the most sustainable models because of this, is how to attract volunteers. Volunteers do love to learn, are very eager to help, and most of them are caregivers or people with lived experiences with some of their patients in their families. So these volunteers are the most people who can really help the patients during their visits to the hospital and throughout all their treatment journey. So attracting volunteers and trying to find different ways to sustain them and more attractions to make them love the hospital, make them love navigating the patients all through the hospital is really a great model to depend on. And this is easier to secure funding for less people and some of the resources and some of the things you need for the patient navigation models in low and middle income countries specifically. So sustainable volunteering strategies are great in the sustainable models that you're asking about. Another thing, to secure funding and to depend on donations, you have to have data. You have to have evidence-based numbers that you can convince donors and sponsors and even attract the grants that can help you sustain a model at your foundation or hospital. So you have to have numbers. You have to prove to people, why is patient navigation important and does it have an impact on the patients or not? For example, we discovered that through the patient navigation services that we are offering, we reduced the number, as I told you, the number of no-show appointments inside the hospital. So when we save this, we have improved the patient adherence to treatment, and this is one thing that we can attract donors by or sponsors. So maybe I hope that this is beneficial. Thank you.
Thank you, Dr. Yoma. Doctor.
Sí, ¿puedo intervenir?
Yes. May I intervene, please?
Por supuesto, adelante.
Sí, muy buena la pregunta.
This was a very good question.
No
As a
solo
matter of fact,
autosostenibles,
not only
conozco
being
algunas
self-sustainable, but I know of
México,
other
en el
experiences,
cual
such as Mexico, in which
modelos privados
the private
comerciales han
models,
sido
commercial
exitosos
models
y
have
rentables.
been also profitable
Y
and successful.
empezaron a
And they started to be foreseen for the patients, and the patients would pay for this counseling, for example, of the navigation. And now the company ceased to attend the patients because it's been used by different health services that have hired these services, providing them for free to the patients. Evidently, the services are even profitable. The thing is that, given the context, and as like Dr. Mara said, every system needs to be proved economically profitable through a research where you can portray the benefits. And with these economical profit, you can go to different systems and you can see, listen, these are the benefits if you implement them.
Dr. Mr. Andriy, adelante.
Thank you. Yes, I would also add that the effect of not sustainable program is devastating for the patients, and we should all remember that. I'm sure we all remember that because there is nothing worse for the patient that when they bring their mom or their daughter into a facility, they get a wonderful patient-centered service, and then a couple of years later, they come back with someone else or to get the service for themselves, and they're told, oh, unfortunately, that program closed down 2 years ago or a year ago because it wasn't sustainable. So we should really strive for the sake of the patients to think about sustainability from the very beginning, from the time when we are just planning our program. And then communicating with everyone and everywhere about your program and communicating these results as soon as you receive them, and communicating the ability to adapt to some suggestions. External suggestions include all of the feedback to improve your program. That's also a part of sustainability. Keeping a check on the costs and making sure that every dollar spent is as effective as possible. And finally, just thinking through this whole donor management cycle, where we don't just go in and write a proposal, but before we do that, we should really be engaged with that donor, maybe for several months, maybe for the year, maybe for longer. And at first you approach the potential supporter without any agenda, just to keep them informed about your activities. And after that, when they know you, when you know them, there is more relationship that's been established, then we can continue to kind of ask and see if that donor is able to support what we need. And sometimes they can, so we have to design to keep relationships with several donors. Of course, the best for sustainability is having some government funding or a co-funding model that Dr. Cazap talked about for recuperating some of the costs. But these are some considerations to have from the very beginning, from the planning stage. Thank you.
Thank you.
Muchas gracias. Hay una pregunta.
Thanks so much. There is a question for Viviana, and what were the barriers that you faced, the main key barriers regarding volunteers?
Con respecto al voluntariado,
regarding volunteers, it presents benefits also, but it presents challenges and setbacks that you need to deal with bit by bit. These challenges mainly would be the withholding percentage that I was mentioning. Try that those that are being trained and that we are investing time and money to train, to give them the uniforms, that they will remain in the program and that they will also become in future teachers. And so the main challenge is how to motivate them as volunteers through training sessions, workshops, events, amongst other key aspects. So this would be maybe the main challenge that I could point. Also, in the Costa Rican context, the biggest challenge we have, a very big challenge, and that we are wishing to overcome, is that the navigation programs will make a part of the health system. Since we are inarticulate right now, we don't make part of the system. So we do have the collaboration and we are working hand in hand with them, but we don't make a part of the system of Social Security. And so we are trying to fix this. Thanks so much. Before exiting the room, please keep your personal belongings with you at all times. Remember, this is an open campus and we cannot answer for whatever may be lost. So we expect to see you here back at 2 p.m. Colombian time. We hope you had a very productive, nice morning with this panel.
Hasta luego. Muchas gracias.
Goodbye, everyone.
Muchas gracias a ustedes.
Bye-bye, everybody.
Goodbye, everyone.
Bye-bye.
Thank you. Thank you. Bye.
Thank you.